All right, good afternoon, everybody. I suggest we get started here. Welcome. My name is Ulrik. I'm a part of Human Bytes, a Nordic supplier of AI and advanced technology for healthcare. I'm here today together with Eske Osvang, professor in anesthesiology at Rigshospitalet in Denmark, who will introduce himself just in 2 minutes in this session here about the intelligent ward, about continuous and wireless patient monitoring with sensors and AI, where we've asked Eske to present some of the latest evidence and research of the value of continuous and wireless monitoring. I'll say this webinar is recorded and will be available for replay afterwards. And just before I hand it over to Eske, just very shortly about Human Bytes. We, as mentioned, deliver AI for healthcare. We have done it in a number of different specialities, AI for breast cancer in the 3 Danish regions and a few other places in the Nordic, where we have published before summer a workload reduction of close to 45%, unnecessary recall are reduced, and cancer detection up. Fracture detection in Region North, we just passed 100,000 patients last week and seen a good reduction in the waiting time in the emergency department, and also reduction in misdiagnostic. Then we have what we call the intelligent ward, having a speech recognition, where we did a webinar about a month ago for doing ambient documenting a live conversation in the ambulatory or at the general practitioner or at the nurses. We have radar technology for fall detection, respiratory, etc. And then we have ward CSS that is designed for capturing the signals from the sensor technology and present them in a meaningful way for the nurses that we'll discuss today. Just before I hand it over, our ambition with this Human Bytes Academy is to bring a new perspective and inspiration for applied AI in healthcare. We have done nearly 20 sessions. You'll find them on our LinkedIn site with a recorded playback. You see them to the right. And then an upcoming one I just want to advertise for is 27th of February, where we look into the choices around sensors for wireless and continuous, and also discuss some more customer experience from a clinical real-world setting here, both in a hospital or at home. So you are welcome to sign up on LinkedIn or post your email in the chat box here, and I'll send the invite for you in Outlook. So without further ado, Eske, I'd like to hand it over for you and to share your screen. And thanks again for helping here with presenting this one.
Of course, you're welcome. Can you hear me?
Loud and clear.
Very good. I'm just getting to the presentation mode here. So thank you all for showing up. It's fantastic to meet so many colleagues from around Europe, although virtually. My name is Eske Osvang. I'm professor of anesthesiology at Rigshospitalet, Denmark. For those of you who don't know our hospital, it is the largest specialized hospital, employing around 12,000 employees with 70,000 surgeries annually. Now, before I start telling about this subject, I also have to disclose that I have a conflict of interest. I am deeply involved in this area, so I have an academic interest, of course, but I'm also one of the founders and inventors of the so-called Ward Project, which we will describe later on in this presentation. My talk here has been approved by the Danish Medicines Board, so I'm allowed to speak as I do today. Now, I'm very happy to take questions after the presentation, so please write them down, and hopefully we will have a good discussion if needed. Now, the Continuous Vital Signs Monitoring, CVSM, is actually a rather novel entity within the general ward. It's quite used in the specialized departments, such as the operating theater, the post-anesthesia care unit, and intensive care, of course. But this system is actually what we're going to be talking about today, is when you start using it in the general wards in the hospital, where the patients are for the majority of the time, and also where the majority of patients are, actually. So this is actually an area where what we do there will have major impact, not only on many more patients than what we see in the ICU, for instance, but also economically wise, how it impacts the whole hospital system, and actually also when sending patients home, which is the future of hospital care. So basically, I'll go through these four major topics: the reduced length of stay and ICU transfer. What is the evidence? The decreased risk of complications, such as cardiac arrest and unexpected ICU transfers. And now we come to something which somebody calls more soft, but actually it's the reduction in time spent on monitoring workload, especially for nurses, but also doctors. This is highly relevant due to the oncoming double demographic burden we're facing, with a much older and comorbid population and fewer working citizens, especially within the healthcare resources. So we need to come up with something that actually can help us when we have fewer hands. And of course, in the end, it all has to align with reduced health costs, so we have the funding to do these things. So looking at the evidence for reduced length of stay in ICU transfers, this is a study by Tanse and colleagues. And actually what they showed is that if only you use quite simple continuous pulse and SpO2 monitoring, actually you saw a reduced ICU transfer. This is a so-called before and after study. But what we actually see here is a significant reduction in the amount of patients being transferred from the general ward to the ICU. Now, what is quite important is actually that other studies have shown that this reduced transfer is not just due to patients being more sick in the general ward, meaning that you simply don't transfer them, because that's also a way of obtaining these data. But actually, it seems as if the number of patients requiring transfer was actually the same. So also that the patients coming to the ICU were on average equally sick in this study, and also others. And these are, for your knowledge, some of the studies showing this. So it's not only Tansa who's done this, it's actually quite a lot of other studies showing that we have reduced length of stay, but also the ICU transmissions. And this is actually across both medical and surgical populations. What you see here is actually some studies quite large, especially the second study, which I will come back to, the Roller and colleagues, over 20,000 patients in a propensity match analysis. I will get back into the details about that study, because that is at the current moment like the hallmark study within this field. Now, from a patient perspective, of course, we need to focus on the decreased risk of adverse events and trying to prevent them rather than just treating them. So in this case, I'm coming back to the Rowland and colleagues study. This is like the other within this field, is actually a before and after study, but although this is a quite large study, over 30,000 patients overall, but then a so-called propensity match analysis, where for each patient in one phase, the before phase, you match them to a similar patient in the after phase. So they have the same risk factors regarding age, gender, comorbidities, etc. And this is actually something that has a quite methodology-wise power to detect differences. What they saw in this study is if you look at the graph here, on the middle dotted line is where we see no difference between the two phases, the before and after implementation of continuous vital signs monitoring. What you see is actually for each parameter, regardless of its being mortality, ICU admissions, heart failure, myocardial infarction, etc., we don't see any we see a benefit towards continuous monitoring. Also, when we combine everything and say, did the patient have one or more of these factors, then we also see this. What's quite interesting is actually the RRT activation, the rapid response team activation, wasn't different, meaning that in this phase, it was actually so that the staff didn't just stop calling, they still asked for help in the same manner, meaning that those patients who needed help actually also got it. And again, coming back to the evidence behind this, this is for you for the slides to be seen later on. A quite important, I think, area is actually that when you dive into the details behind what CVSM allows you to do, is actually pinpointing some quite specific improved areas. So, for instance, we see there is, in this setting from Norway, we see there were fewer hours towards regaining mobilization. That could have been due to the fact that the patients actually required less opioid on average, but still they had less pain in the continuous vital sign group. When you go into the details of this study, you see that what is possible actually by doing this is having a much more targeted intervention. Instead of just giving something and don't have the time to come back and reassess, you have a quite nice ability to monitor each patient specifically and thereby titrating the treatment. This also shows in the patient satisfaction that was increased in the group monitored with these systems. Coming back to the quite important factor on is this only obtained by increasing the amount of resources we use? It's so actually that we can see using the studies within the ward project that actually for each patient monitored, when you remove all the time spent on putting the equipment on, actually logging into the system, etc., you still save more than 10 minutes per patient. Now, this may not sound as a lot on overall, but if you look at the graph onto your right, what you see is that the more sick the patient is, the more time savings there are, because according to the current standard early warning score, you actually have an obligation to increase monitoring frequency substantially the sicker the patient is. This is actually, when you combine these numbers, this is actually, we have 20 patients monitored, equivalent to freeing up a full-time nurse to do other tasks. Now, what is important about, in this case, the early warning score, or national early warning score, which we can see is used throughout Europe as this clinical standard, is actually that in the novel algorithms, there is actually a recommendation of implementing and using continuous vital signs monitoring when you have quite sick patients. This is simply because we can see in other studies that staff simply don't have time to adhere to the escalation protocols, meaning that although you have to go in and check the patients every 15 minutes, you simply don't have the time, for instance, if you're a nurse with like 5, 10, 15 patients per shift, per nurse. Also, another important study here from Norway again is actually that the nurses reported that these systems actually increased the patient satisfaction and quality of care. And this is actually also, again, shown in the reduced time of monitoring by the nurses. Now, a slide I haven't brought with me here is actually the studies from our Dutch colleagues showing that if you ask nurses, how does it feel to be in a ward where patients are monitored like this? They all report an increased sense of security. And actually, this is especially during the nights and evenings where there are fewer nurses than there are in the daytime. This is quite important, actually, we believe, because this is also about job retainment, making sure that staff feels that they are able to look after the patients they are caring for. And overall, it also means that we might have better ability to reduce sick leave, etc. But this has to be shown in future studies, of course. Now coming to the more hardcore reduced health costs. What is actually the case is that if you have a complication, the surgical complication will increase the cost of a hospital stay by at least 1.5%. This is the same as a 40% increased treatment cost after complications. And we see in various publications that almost 9-10% of the total health expenditure worldwide is actually used on correcting from injuries that could be avoided. And indirectly, these numbers are really, really, really high. And this is something that plays into the whole discussion. Can we afford to implement these systems? Well, first of all, I believe we have to do it because it's basically something we can do, and we choose not to benefit our patients while we're not doing it. I will also argue that we could actually do a lot of anesthesias in the OR without monitoring the patients. But we would never do that because we know we could actually prevent some quite severe cases of injury, even deaths. But for some reason, we choose to turn the blind eye to what's happening in the general ward. These are the estimated cost savings by Beard and colleagues when you implement continuous vital signs monitoring in a general ward, outside ICU, PACU, and so on, in 25 beds. And what you see is actually a absurd number of money saved in these situations. Again, coming back to whenever some administrator says we can't afford it, I would argue, can you afford not to? Because you're saving money, which makes you poor actually in the end. So the details within this is actually that when you implement these early detection solutions, it's driven by three main areas. It's driven by reduction in length of stay, meaning that actually the patient leaves sooner, meaning also you have a more efficient healthcare system because you can treat more patients within the same beds. The number of medications used are decreased. We also see these in our own unpublished data for now, which actually shows that even though this is some kind of screening tool, we don't see an increased use of medications, examinations, etc. We also see a lower pharmacy and IV costs simply because we have fewer complications. So within 1 year, you actually have a return on investment. And in 5 years, you have a return on investment almost up to between 100 and 800% from doing this. And even an absurdly low number, even if you just reduce the respiratory depression, it's been shown in studies that this actually results in a break-even investment point from continuous pulse oximetry and capnography monitoring. Now, all this sounds fantastic. It sounds, why don't we just do it? Well, the main problem in doing this is actually when we start doing this, implementing continuous vital signs monitoring in the general ward, regardless of it being medical or surgical, the same thing that happens in the OR, the PACU, and the ICU happens in the general ward, which is that we have absurd number of alerts actually. I would say that the number here, 100 alerts per patient per day, is actually low. It's normally much more, sometimes more than 200. And similar to the ICU and PACU, the majority of these alerts are actually false, I would say, irrelevant alerts, meaning that the alert actually goes off because the pulse, for instance, is high. That's not a false alert. But the fact is, this pulse increase has nothing to do with an oncoming complication. It's simply just a normal variation in physiology. And we need to remove these alerts because otherwise we will have the so-called alarm fatigue, where we are desensitized to the alerts, and in the end, we ignore the alerts that actually matters. So the consequences of all these alerts is work interruption and delays, more workload by stopping the alerts, and we actually miss those patients where they actually needed to be attended to. In the end, this results in critical events and sometimes even patient deaths simply because of alert fatigue. Now, what is actually the two strategies here is either adjusting alert thresholds or having a predictive risk analysis. So adjusting alert thresholds has some effects on patient safety. You can actually start adjusting so that you get no alerts. This is the same as we're doing today where we don't monitor, but you can just choose so low thresholds for so long that you will never actually find something because the patient might be dead before you do. That's a very efficient way, but also a very unsafe way for the patients. The other hand is predictive risk analysis. It has some sort of limited clinical utility because it actually means that you tell the patient on the ward, when you're with us, you have so-and-so risk of something happening to you. It also means that you might be increasing the workload of the staff because simply they have to attend to patients who actually turn out not to have any problems. The problem is that it doesn't solve the issue when a patient with a low risk gets a complication, which is quite severe. So there is a need for intelligent layer on top of the continuous vital signs monitoring. And this is stated by Vincent and colleagues, that we need a system that correctly interprets the monitored variables and actually tells the staff when do you need to call for help and when do you not need not to do it. The same was actually proposed by Michaud and Saugel earlier this year, so that we need some alert thresholds and association delays. So when these are used, they are actually evidence-based and linked to an oncoming complication. And in the end, of course, we would like to have some personalized thresholds, but this is still something that is not safe yet. This is still not something we have the evidence to do. So right now, we recommend some general alert thresholds, albeit with some twists, which I will come back to. So what we've done in the WARD project is actually to simulate the way an experienced anesthetist or perioperative medical person thinks, which basically is combining deviations and the time that deviation has occurred. I'll come back to that later. We then used the last 8 years to validate these and fine-tune these thresholds, both through systematic and narrative literature reviews, and also clinical annotation studies, meaning that we actually try to see, is this threshold actually related to a certain incidence of complication, or is it simply a very low, although it's a deviation from normal physiology, is it actually something that has no real relation to complication? Then we shouldn't alert for it. So basically, we have 3 principles. The first one is that a severe vital sign deviation is more clinical relevant the longer it is endured, both as the accumulated time you spend outside normal ranges, with short episodes interrupted by normal physiology, but also especially sustained episodes of longer duration below specified thresholds. We also believe that it's important to not only go for those thresholds which are very much deviating, but also have some less severely deviating vital signs if they are combined with vital signs from other organ systems that try to compensate for the deviations. The most classical one being the increased pulse, in some cases of hypertension, for instance, the increased respiration rate, in some cases of hypoventilation. So, and lastly, of course, the further deviation is from normal, the shorter the range of time we allow to happen here. This is basically what we do in clinical standards. And these are some of the current alerts which we're using. As you see, it's within each of the organ systems and vital signs, which we also already use in the early warning score. The whole idea of starting with the early warning score and modulate the system on top of this is actually on purpose, because it means that the staff doesn't have to get acquainted with something extremely novel. It's just a novel way of interpreting the deviations, but for them, it won't be something extremely novel, like, for instance, sympathetic activity, which is potentially something that can be used in the future, but nobody knows how to handle it right now. I also, tongue-in-cheek, call these the anesthesia coffee principle, meaning that if it's a very moderate or minor deviation, I'll tell the nurses, I'll go get some coffee, I'll come back later, because I know this will go away in the majority of cases, and then I have to do nothing. On the other hand, if it's a very severe deviation, I'll tell the staff, please hold my coffee, I'll go check on the patient immediately. So how can the ward clinical support system enhance the patient flow in the system? Well, basically, we have these systems. We have the ICU, which is extremely costly. We have lots of nurses, and the standard of care is continuous vital signs monitoring, albeit wired. We have more than 100 alerts per patient per day. In the OR recovery, that's a very low risk of mortality. And again, the standard of care is continuous vital signs monitoring. Actually, in the emergency department, there is actually no continuous vital signs monitoring per se for each patient, and there are periods of very, very high demand. What we don't always have is the step downwards, where we do have the continuous vital signs monitoring. Here we have a lower nurse to patient ratio, but in the end, all the patients end up in the general and medical surgical wards. These patients have a very low nurse to patient ratio. The standard of care is intermittent monitoring 2 to 3 times a day at best if you are stable, and then of course you have to be lucky if you become unstable in between these 8-hour, 12 hours delays. These delays result in the fact that 95% of vital signs deviations are missed. This is actually quite important because by far the majority of post-surgical mortality occurs in the general ward. Very few occur in the ICU and the OR, basically because so few patients are there. The rest of the complications actually occur at home. So as proven earlier, the use of CVSM actually might or does actually result in less ICU transfer and reduced length of stay. When we go to the home setting, I'm sorry, just have to remove this one. We see, as I said, the rest of the mortality occurs here. In the home setting, there are no monitoring. There might sometimes be self-monitoring, but that is also not continuous. This is intermittent, and the patient has to be well enough to monitor themselves. So if they, for instance, become unconscious or severely impaired, meaning that they are too tired, they might not monitor themselves. So in this project, we have worked on how do we use our system to make home monitoring possible, allow for earlier discharge, and actually also reduce readmissions, but also actually reduce the primary admissions if the admission was only for monitoring alone. 1 second. Now, we have estimated that this is, of course, just to start somewhere, that the monitoring we are suggesting is indicated in at least 25% of hospitalizations. This is actually focused down to quite narrow populations: major general surgery, orthopedic, OB/GYN, urology, cardiovascular surgery, which actually has a quite high risk of serious complications. You might choose to use it in lower incident populations, but this is where you really get your bang for the buck. The rest of the in-house complications is from the fact that the medical admitted patients for pneumonia, acute coronary syndrome, heart failure, and sepsis, also on top of the primary injury, suffers a lot of complications which we need to detect early on. Other kind of patients you might want to monitor more frequently are, for instance, the chronic patients admitted for exacerbation in COPD. They have a lot of complications, but also importantly, per current standards, there is a need for very tight monitoring of these patients. Actually fixating a whole nurse for that one patient during the shift, because they need to be monitored every 15 minutes. Now, with continuous vital signs monitoring and automatic registration, you can actually do this without going into the patient because it's monitored automatically. So the use case here is the surgical population, where we can see in our data that serious adverse events occur in almost 40% of the patients. There are lots of tachycardia occurring, and in this case, we have a lot of the patient cases actually being tachycardia, detected by tachycardia, lasting more than 60 minutes above 110 in pulse rates. What we can see here is actually that the patients with complications have more of these deviations than patients without. What we also can see is, I'll come back to this, is a severe reduction in complication rates on day 7, for instance, going down from 22% to 30%. We've also been studying it outside the surgical population, the oncology and hematology. These are extremely vulnerable patients at risk of infections. So the patient actually feels that somebody looks after them, they feel safe, besides the ability to detect complication much more earlier. What we are going in for right now is actually whenever we treat the patients with immune or chemotherapy, primarily in hospital, we put the system on and see a reduction in time spent by the nurses going in and checking, can the patient actually accept the treatment, or do they actually get a adverse reaction to the drugs. Psychiatry we have a use case where we use it in patients admitted from withdrawal symptoms from alcohol or substance abuse. Extremely important. It might very often result in either arrhythmias, primarily tachycardia, but also in some of the treatment cases, you have desaturation from opioids and other drugs used to counter the side effects from withdrawal. What is possible is actually to choose to scale up or down. For instance, that if you have a patient population where you say, well, the majority of patients here are affected by primarily tachycardia, then we can simply just use the simple solution with the ECG patch on the chest. We don't need to put, for instance, the saturation monitor on. That can be chosen if necessary, but actually the system, the ward system, is so flexible that we don't need all sensors to be working. These are ongoing studies for the at-home situation. And as said in the beginning of my talk, this is where we need to have a much bigger focus if we want to prepare the hospital systems for the oncoming situation with lower staffing and many more patients. And what you can see here, these are an analysis of how often do patients actually call an emergency hotline after discharge. And what you see here is actually each patient in the upper graph here with sepsis being discharged after sepsis or ACPD or other respiratory diseases. They actually call somewhere between 15 and 20 times per patient day, meaning that they are flooding the system immensely. Other kind of population also calls a lot. But also the surgical population, you see that each patient actually calls a lot per 1,000 patient days here. So alone the number of patients results in a substantial amount of telephone calls. And with this system, we hope to, of course, reduce the need for calling the hotline, because we can tell the patient and staff, everything is fine. You don't need to worry about this. Your deviations looks fine. There is no one that is serious, and you can actually relax. And we will alert you if something severe occurs at home. This is a case report from the cardiology department in our Portuguese test center and colleagues. This is a case where a 75-year-old patient was admitted for cardiac surgery, and then he was actually gone to the general ward with 2-day post-surgical. The patient was monitored with the system. We saw some severe desaturation episodes in the night. The nurses went and checked. Actually, the manual SpO2 measurements were normal. The sensors worked well. The nurses increased the O2 flow. And what happened is actually that this was a case where the information was used for an internal discussion with the medical team. And what happened is that this patient was actually diagnosed with sleep apnea, which wasn't known beforehand. So in this case, you can see that we actually were able to detect something that wouldn't have been detected without. So these unnoticed severe desaturation episodes might not have been detected by the usual round, because as said earlier, we normally fail to detect these things in 95% of cases. So it could either have increased the risk of hypoxic complications, heart injury, etc. But it also might have meant that the patient would have been sent home with sleep apnea, and something could have happened at home when nobody could have done anything for the patient. This is in my own hospital, a patient being admitted for surgery with chronic pain. 1 second. In this case, the department was actually quite nervous that this patient, who was on very high doses of opioids, should be handled in the general ward. They actually at first required that the patient should be admitted to the ICU, but after being offered the possibility to monitor the patient with the ward system, they agreed to have them there. So what the nurses could do is they could call the department, and as we said, they start using the system to monitor this specific patient. What actually happened is that this patient's pain was managed well. The cases of desaturations turned out to be fewer than expected, and the one cases that were there was actually handled within the department. So either this could have resulted in some poor pain management because the staff could have been afraid to titrate and increase dosages because they were afraid I would say relevantly, that these cases would not be detected and something could happen to the patient, but actually we managed to monitor well and increase the dosages safely. And with this quite intense presentation, I would like to thank you for your attention. And I'm extremely happy both to answer questions right now after Ulrik has said some more, but also if you'd like to reach out and discuss, I'm more than happy to engage in conversation. This is actually what I live and die for. Thank you.
And thank you, Eske, for a very comprehensive presentation here. Again, if any questions, please put them in the chat or unmute the phone. And before you drop out, if you like to get a demo or discussion around it, please just write us. We can come over, and also we have the opportunity to set up a 2 or 3 days real use of the system to try it to make a local validation of the system without any deep IT integration, something we done last week in psychiatry, for example, here in Copenhagen. So any questions, please unmute your phone and maybe allow me for first one here. For patients at home, we have interest for TAVI patient, nephrectomy, chemotherapy patients, or even a geriatric patient. What's your perspective on this, Eske? Is it more confident to send patients home earlier with this, or
well, I would definitely say yes. I think that what is needed right now is not the technology, because that works, and the technology works very well from home also in reducing the alerts. What is, I would say, the obligation for each place that wants to use this is who gets the alerts, who are the call center or the staff. And we tried 2 different solutions. We have tried the solution where the hospital, this was the emergency room, actually received all the calls from patients being discharged from them without being admitted for observation only. That worked well. Another situation was actually a hematological department, because they know their patients. Each patient is not somebody they have to get acquainted with. So these departments actually got the information directly to the on-call doctor. So they could talk to that patient they know, and they could actually decide what to do.
Great, thank you. And I think we have a question from one of our participants from Iceland. Hi, Buddy.
Hi, thank you for an excellent presentation. My name is Thor, and I'm the CEO of the Surgical Perioperative and ICU Department at Landspítalanum in Iceland. And I was just wondering your experience with these microsensors used to gain the vital parameters. They're often sensitive to a lot of things in the environment. And number 2, does this monitoring devices restrain patients from mobilization?
Well, excellent point. I'm sorry I didn't touch upon this. So Christian and I, we decided very early on, this is the same for the rest of the team now, that all sensors should ideally be wireless, because and adhering to the enhanced recovery after surgery principles, I was trained under Henrik Kielitz, is actually pivotal, of course. We don't want to keep the patients in the beds. We want the patients up and moving around, being active and so on. So yes, all the wires are wireless. Sorry, all the devices are wireless. We don't see any device interaction with external ambient noise, for instance. All these devices we're using, we're not a device project or company. It's actually so that we are integrating with all CE and FDA approved device producers. So you can actually choose whatever kind of device package you want. What we're offering is actually an interpretation with a AI augmented system that helps you reduce the number of alerts. So I would say that there are quite a lot of device producers out there. You have to find out which one suits your needs the best. Which one do you think likes the most? We have our own assessments. We actually have chosen to validate ourselves before we are accepting devices into our system, because we believe we need to do that. I'm sorry, just a little comment further, is that a lot of the device producers have actually only tested their devices on healthy populations. And if you look into their publications, you will see that very rarely are there deviations being validated in the abnormal ranges. It's normally in the normal ranges, normal pulse, blood pressure. And as doctors, I don't really care that you have a normal pulse and blood pressure. I need a system that is able to correctly show me the deviating signs.
Exactly. Do you do any patient selection? Do you choose to only monitor high-risk patients in your department?
It's a very good question. No, actually, we choose to monitor patients. If you have like a two-dimensional graph, you can have a patient with chronic severe disease, and we believe those patients should be monitored. And then you have a high-risk surgery. We believe those patients should also be monitored. If, for instance, in this case, if you have a low-risk surgery and a very well patient, we don't believe those patients need to be monitored because the benefit is so little. We can also see that in the time consumption study, that very well patients are doing very well with low risk. There's actually very little time gain there. Of course, in the future, my wish is that each patient admitted to my hospital will always have an ECG patch. So I will never find a patient dead in the bed next morning, because we know even very healthy young sports people sometimes die spontaneously. But technology today should allow all of us working in hospitals to find those patients, even if this would happen at home also. But right now, we do believe that around the 25% of the population hospitals is a target population.
And Eske, maybe I can just ask.
I think there was another question. I thought.
Yeah, but just
I just wanted to thank you for again for the presentation and good explanation. Thank you.
Thank you.
And Eske, maybe also to follow up on this question here. I know you just analyzed, I think it's 9 million early warning and how it affect the mortality within 24 hours, and that led to some changes in the guidelines for early warning scoring in Copenhagen.
Oh, this is correct. This is correct. I think I mentioned it briefly. What we can see in the novel early warning score, or actually the novel recommendation for monitoring of patients here in the eastern part of Denmark, is that if you have a low-risk patient who has a very low early warning score to begin with, then we really reduce the amount of monitoring. So we don't use blood pressure, for instance, to begin with. The moment you start deviating more, then we suggest to put on blood pressure also in the intermittent ones. But once the patient starts getting quite sick and early warning score 6, 7, then we recommend using continuous vital signs monitoring just to reduce staff workload alone, but also to find those cases where it happens in between.
Yeah. All right. Any other questions here? Otherwise, I would like to thank everybody for participating, and especially you, Eske, for taking the time to guide us through some of the studies and data here. And the session is recorded. We'll share it if you want to share it with colleagues. And feel free to reach out to Eske or me in case of any need for further elaboration or presentation. So thank you, everybody, and have a continued good day and a Merry Christmas once you get to it. Bye-bye.
Thank you.
Thank you. Bye-bye.
Bye-bye.